Thank you. Senator Roth.
You know, my background, at least in part, is in the military, and we tended at least in the old days to have exercises, and the exercises were not regional or local, they were more national in scope. My perception is, with respect to emergency management, and my perception may not be totally accurate, is that a lot of the exercises that occur or are local or sub-regional, maybe even regional, but not statewide. And so as we go through this process and as we plan, I'd like to see some planning for a more statewide approach to an emergency management exercise. Perhaps some of it will need to be simulated. I'd like to see what is proposed to be done to move the mobile hospitals to areas of need, how you're going to get them there, how long it's going to take you to get them there, whether you're going to put them on a C-130 out of Port Hueneme or whether you're going to put them on the back of a flatbed. I'd like to see that. I'd like to see the planning done. I'd like to see what the cost is. I'd like to take a look at that in the next budget cycle, because I think as California, it's incumbent on us to make sure that we have planned appropriately. And unless you exercise your capability, my experience tells me you don't know whether it's going to work or not. So I'd like to see us plan an exercise. I'd like to get a cost estimate for the exercise, and I'd like to see whether we can build that into the budget this next budget cycle. Maybe we don't do it every year. Maybe we do it every 5 years, but we at least ought to do it sometime, somehow, to see whether what we have really works. So that's my comment and my request of you all at the table here. Thank you, Madam
Thank you very much. And if we could move along now to California Office of Emergency Services, to our next speaker. Good morning, sir.
Good morning. Good morning. My name is Mustafa Abu Talib. I'm the Preparedness Branch Manager for the California Office of Emergency Services. Thank you, Madam Chair and committee members, for giving us the opportunity to highlight OES's role in emergency management, including medical and disaster preparedness. The Governor's Office of Emergency Services is tasked, and its mission is to enhance safety and preparedness in California. We do that through collaboration, leadership, partnership with our key partners, state level, local, private, and the federal government. Our mission and our goal is to save and protect life and property in California. OES is responsible for coordinating the overall state agency response to an emergency or a disaster in support of local government. And we plan and we prepare and respond for an all-hazard type of an approach, meaning, earthquakes, floods,
oil spills,
and of course the current drought. We're leading the task force on the current drought. Emergency management is a whole community effort. Nobody could do it by themselves. The recent big events in the whole nation showed that. So we are a very strong partnership with our federal government, FEMA, leading the effort, with our state agencies, with our local governments, and private sector. Studies have shown that the private sector owns more than 90% of resources in the nation, so they have to be part of that common operating picture. As EMSA mentioned, OES's cornerstone programs are the Standardized Emergency Management System. It's a multi-agency, multi-jurisdictional system that brings in all the players together during an event, and you can communicate in one fashion. We could request resources. We could give that common operating picture that helps help local governments recover. The other part of our system that's key is the state emergency plan. It's the blueprint of how we do emergency management in California. It sets the roles and responsibilities, the authority that's given to us, and everything that local governments and state agencies do to prepare for disasters. We just concluded last week actually a flagship exercise for the year. It's called Capstone. It was based on the Southern California Catastrophic Earthquake Plan. We had key partners. It was a full-scale exercise, key partners from all over the federal government, the state agencies. EMSA and Public Health were one of our biggest partners in this exercise. The local governments were simulated in this exercise. We had Department of Defense, National Guard, and all different elements of Department of Defense. And again, we exercised the deployment and movement of resources in response to a catastrophic event in Southern California based on that plan. Another big, massive effort of planning that we're doing is the Bay Area. catastrophic earthquake plan, which is the equivalent of Southern California. So again, we partner with FEMA, and this plan is being rewritten now as we speak, and partner with our partners at Public Health and EMSA. We look at the Bay Area, the local governments, where the surge capacities could happen. How do we plan? We've got models by our scientists that show us where the damage could hit, so what hospitals are going to be out of commission. And then we start looking at numbers with our experts here and come up with a plan for establishing, pre-designated areas where these medical teams will deploy to. These areas would be verified after an event, of course, to make sure that they're still available. So that's just an overview of OES's role in emergency management and how we could support this effort. I'm open for any questions throughout the event. Thank you.
Well, let me start off, and then, Senator, did you have a question?
Well, I just have a question about hospital reconstitution. So, we saw this with Katrina, and I happened to be sitting on a hospital board at the time, and I asked some questions of administration, and I'm not sure I ever really got a very good answer for how they plan to reconstitute their treatment facility if the facility itself was gone. How do you test the capacity of local hospitals that you've projected to be demolished to reconstitute, other than putting it in a plan? Are the people on the ground, for example, in Anaheim, going to know what to do and where to go, or is everybody going to be scrambling around until you all land and with the bullhorn get people organized?
Thank you for your question. I'll talk from the planning perspective, and of course Public Health and AMSA could speak for the technical part of it. All our plans include local governments and everything. It's based on local government, a situation. So we don't go in and tell them what's going to happen. We actually build it from the bottom up. So the scientists give us a scenario. Local governments are there to kind of help us validate that scenario, and then they give us the information needed to build that plan. So it really comes from them saying, these are the hospitals are here, here's the capacity. The event is showing us that the strongest shaking, for example, in an earthquake will happen here. Therefore, we're going to have to assume that these hospitals are going to be out of commission, the strongest shaking areas. And then we started building our planning effort there. So it's a bottom-up approach when it comes to planning. I'll defer to Public Health or EMSA to talk about specific surge.
So I would also talk about the healthcare coalitions that are in every operational area or county where they are building a continuum of care to look at as one part of the system goes down, how do other parts of the system pick that up? The other piece that I think you have to look at is the systems approach, where we have the Kaisers and we have the UCs, which will use their system resources to move patients around. And we know that will happen in any catastrophic event. Either they will move staff from one place to another, or they will move patients through their systems as they try to get treatment.
Couple questions. One is, after you did your full-scale exercise, did you notice any glaring problems that you're planning to address, and would those require additional financial resources to do them?
We are in the process of developing our corrective action plan for the exercise. It just concluded last week. But from my observations, the heart of any disaster is going to be about moving resources and pre-positioning resources ahead of time. These catastrophic events, like Public Health mentioned earlier, are all based on there's going to be so much going on, you're not going to get a good feel of what's happening and what's needed immediately. So you have to push, and FEMA is very big on this. After Katrina and what happened nationwide in the last decade, they are not going to wait anymore. So they're waiting for us with pre-designated, staging areas that we are going to push stuff down there. And then as things get refined, we're going to figure out exactly where needed. But we're going to be ahead of the game in that value. So it's all going to be about resources and movement. So more planning, more exercising, more tactical and logistical support to move these using our partners in the Department of Defense, National Guard. All that is needed. So we're going to continue working in that effort.
And one more question, then I'll pass it along to Senator Roth. I'm assuming that if we were to have a catastrophic event or something, that both public and private sectors are going to be equally and fully involved. Is there any question about whether or not the state would have the authority to require the private sector, some of these private facilities and hospitals, to participate for the benefit of the public in a public emergency?
I don't think that's ever been a question from our facilities. I think they're all willing and want to come to the table during emergencies. And I think the pieces that we could do more work around are the liability issues and some of the that allow them to do the work that they need to do. I don't think it's a question of them wanting to do the work. I think that's why they do what they do.
Well, I hope you're right, but if there are some things that, to make sure, I mean, at some point we will all be in this together if there is that kind of an event, and there shouldn't be any impediments whatsoever to bringing all the resources available together, irrespective of whether they're private or public. This
that's
is
what
really
the healthcare coalitions have been building,
Okay.
the ability to share those resources among one another during events. And we've seen that in smaller scale events with the sharing of PPE, with the sharing of assets between facilities so that they can get them there very quickly.
Right. Senator Roth, thank you.
So when you have these exercises, I assume there's an after-action report that's a candid report that's an evaluation of strengths and weaknesses and opportunities and challenges. Who sees that report? Does that report come to, does a copy come to this committee's staff, or does it go to the budget subcommittees that deal with state administration, or both? And if not, I'd like to suggest that the director consider doing that.
Yes, thank you, sir. Yes, we definitely would provide a report to this committee, and we'll make sure that happens. The report is public if somebody requests for it. We do put the executive summary on our webpage for everybody to see, but the more detailed, down to the details, that is a public record request could come in, but we could definitely provide it to the committee, the whole full report, once it's complete.
Well, I'm not the chair or the vice chair. I'll leave it to them, but it would certainly be my suggestion that happen.
Yes.
I think that might be a very good idea if you could provide a copy to the members or perhaps to the chair's office, and they will be distributed to all of us. Senator Bates.
Quick question. I do remember when we had our county drills that we were graded by FEMA on whether we were meeting the level that they required. Is the state graded by FEMA in terms of this overall coordination with the locals? Is there any sort of?
I'm also over the radiological programs, the two power plants in California. So the NRC through FEMA requires graded because it's tied to the license of the facility. So yes, those are graded. We are not graded in the same fashion by FEMA and other emergencies, but there are ways for us and them to sit down and go over these after-action corrective action reports and figure out the areas where we need improvement and how we establish. But it's a little bit different for the radiological programs because of the tie to the licensing from the facilities.
Yeah, that's what we did, but I think that would be very helpful in terms of informing all of us, in terms of our responsibility as if we had the after-action task following a drill. Then I think there'll be a higher level of comfort that you all have it together, because I'm not so troubled that we don't. Serving at the local level and being on the EMS committee for a portion of the time that I chaired the Board of Supervisors. So that it's kind of information that we need.
We are graded on our strategic national stockpile, both at the state and local level, our ability to move federal resources, and we do get graded annually on that. And we've done very well from 98 to 100% on those.
We have an annual emergency preparedness forum in Orange County, and all of the local emergency management folks are there. The water district comes. Everyone that would be involved when something like this happens, a disaster. And then with the infectious diseases, we've had a vaccination drill every year.
Yeah.
So
And that's occurring in most of
I
the
think
counties,
local governments are doing things that perhaps haven't drifted up here, so we're all comfortable that there's a coordination. So. Anyway.
And I might say, with that in mind, the whole issue of coordination, I know at least several years ago, there was some frustration between different cities and counties that their communications systems were not in sync, and that there was some discussion about trying to make sure that analog and digital weren't competing with each other, if you will. I know that's old news, but or an old technology, but are we now at a point where the system is sufficiently seamless so that the communications networks between cities and counties are consistent so that they can essentially talk to each other during these important moments and hours after or while we're addressing one of these emergency situations?
I know that our public safety communication group is continuously working on this effort, and it's one of their key objectives. So I don't have the details, but I could get that information for you, Madam Chair.
I think that'd be helpful. I know continuously working doesn't tell us whether or not they're there, how much more they need to get there. I know different cities, different counties within our jurisdictions don't necessarily coordinate because they don't have that communications ability. So we can direct them all we want to be in communication, and they will tell us that they would like to be, but they have different systems in place. And so, again, if we had a disaster, I don't think the public would be very impressed by that explanation.
Our healthcare facilities and our our healthcare coalitions have invested in radios so that the local government can, the local health department and local EMS can talk to the healthcare facilities. And so they update those annually to make sure they have that.
So that would be helpful to know whether we're all working in that, and what again, you know, if we have the ability now to try to upgrade and update ourselves so that if and when an emergency strikes, we are able to serve the public as they are entitled and as they expect of us. That would be helpful as well. Dr. Penn, did you have a question? No. Okay. Thank you very much, sir. Let's go on to our next witness from Cal OSHA, Mr. Papanek.
Madam Vice Chair and members, I'm Dr. Paul Papanek. I'm an occupational medicine physician with the Cal OSHA Medical Unit, and I'll be brief. Cal OSHA's role, of course, is not to be a first responder, but to protect the workers. We've learned some lessons, I think, from previous disasters, 9/11, of course, where we learned about the difficulties of protecting workers' airways when dust burdens are difficult. In the Ebola disaster, we learned that California's infectious disease regulations with regard to workplace safety really are, I think, a model for the nation. I would stress that that standard, which hospitals are now aware of, it's been in effect for about 5 years, has built-in flexibility in that in the event of a public health disaster, it specifically defers to the state health officer about what hospitals must do to protect the airways and the skin of healthcare responders. We've been involved previously in a number of surge responses. For example, the H1N1 outbreak in San Diego now 5 years ago. We were on site quickly to do fit testing and deployment of respirators. With regard to Ebola, of course, we collaborated with all the site visits to the state hospitals. I would just say that additional surge capacity with regard to our agency, there's an agreement with federal OSHA, our federal counterparts, to provide mutual assistance in the event of a disaster. As a counterexample, after Katrina, between 5 and 10% of Cal OSHA's enforcement staff were deployed to New Orleans to assist with that. And so we have the ability of swapping resources with other state agencies and with our federal counterparts. And with that, I think I'll stop and take questions. Thank you.
Thank you. Are there any questions? Dr. Pam.
So just briefly, I heard that one of the challenges in trying to address Ebola, and I think that this probably speaks more to infectious disease, right? You have a contagion, you need to try to limit it. You hopefully don't want to lose too many of your professionals in the process of trying to take care of them. And then in terms of, you're talking about supplies like suits and masks and so forth, and we talked about medications and availability, but also and people are swapping in and out of them and so forth. Do we have? What kind of capacity do we have in terms of? You have an outbreak and you need to contain it and so forth. So.
It's a great question, Dr. Penn. I may defer to my CDPH colleagues who maintain stockpiles. We know that during the recent site visits, that we expected that the hospitals would have at least a few days capacity on site, and then we would be able to move resources around for at least 2 or 3 weeks capacity to any hospital within days.
Well, that actually, I think it was speaking as much to that. There's the state reserves, but there's also what capacity do you expect to have on the front line, just given the nature, and obviously that's a cost to the hospitals too, right? I mean, hopefully they're not having to use them every day, but then having a couple of days before the cavalry comes in, you do need to be sure your frontline workers are able to operate and stay safe and not actually succumb to whatever's happening. I mean, they will face potential, obviously earthquakes, injuries, other types of things can happen as well. But how do we be sure we keep the workforce available?
Well, it's a great question. One of the things that we're looking at this next year is the consultation service within Cal OSHA has outreach focus each year, and this year we're in response to Ebola, we're looking at making a special emphasis outreach to healthcare facilities to re-educate about the ATD standard.
And I guess just final question. I mean, are you thinking about establishing any standards so to be sure that we have that capacity in our frontline institutions?
Yes.
So, and we have been able to use both hospital preparedness program funds and some of the Ebola funds to purchase caches of PPE that address the Ebola situation, because when we were buying our caches, we were looking at a pandemic influenza, and some of the ATD and bloodborne pathogen standards aren't met by that PPE.
Thank you. Our last speaker in this panel is with the Department of Healthcare Services, Claudia Christ. I hope I pronounced that properly. And if you go ahead and give us 5 minutes.
Okay. Thank you, Madam Chair and members of the committee. I was asked to address 3 questions specifically. This is Claudia Christ from the Department of Healthcare Services. I'd like to start by addressing the question around, since the implementation of the Affordable Care Act, whether Medi-Cal has seen an increase or a decrease in emergency room visits. At this time, of course, the optional expansion was implemented on January 2014. So at this time, the majority of the population is in managed care, about 80%. Calculation of that population's experience regarding increase or decrease in outpatient and inpatient utilization isn't yet available. However, the Low Income Health Program, or LIP, was implemented under the California Section 1115 Medicaid waiver, and the LIP was California's precursor to the Medicaid expansion with significant overlap in the eligible populations. So from July 1st, 2011 until December 31st, 2013, over 10 million medically necessary services were provided to LIP enrollees. Experience from that program can be used to identify likely patterns and trends under the expansion. The UCLA Center for Health Policy Research published a health policy brief titled "Increased Service Use Following Medicaid Expansion is Mostly Temporary, Evidence from California's Low-Income Health Program" in October 2014. This UCLA study indicated a significant decline in hospital inpatient care and emergency room visits occurred in LIP after the first year of enrollment. At the same time, the rate of outpatient services stayed stable, constant. The health policy brief concluded that pent-up demand of newly eligible Medicaid enrollees declines rapidly after the first year of enrollment and becomes comparable to the demand of those with previous comprehensive coverage. And secondly, it concluded that for populations who were pre-enrolled in coverage programs prior to the Medicaid expansion in January 2014, much of the pent-up demand for expensive emergency room and hospital care had already been met. Approximately 650,000 of those LIP individuals transferred directly from the LIP program to Medicaid on January 1st, 2014. The other questions we were asked to address, was really around what the Department of Healthcare Services is doing to educate individuals and new beneficiaries of Medi-Cal services in order for those to receive the appropriate primary and preventive care and trying to avoid the use of emergency rooms. So DHCS does work in partnership with the Department of Managed Care to review plan member information materials, including the evidence of coverage notice, as well as the member handbook and the managed care health plans that they create and provide to their beneficiaries. This evidence of coverage and member handbook provide a wide range of information on the benefits that are covered and applicable costs to the members, as well as information on how to access the plan's benefits, an explanation of their rights and responsibilities, and who the members can call for questions. This includes information on primary and preventive care services. Additionally, the department maintains the Healthcare Options website, which allows beneficiaries to search for available Medi-Cal managed care providers near their residence. And to further ensure that Medi-Cal beneficiaries have information on how they can maintain their doctor, medications, and health care when they move to a managed care health plan, DHCS also created a continuity of care website. Lastly, we were asked what DHCS is doing to help beneficiaries in finding primary care physicians or a managed care plan. So, couple of different ways. For the non-county organized healthcare systems, or COS counties, beneficiaries receive a Medi-Cal choice packet within 1 month of eligibility determination, and this is in addition to the Welcome to Medi-Cal package that all beneficiaries receive once they're found eligible for Medi-Cal. This choice packet lets the beneficiary know their managed care plan options in the county and provides information on each plan and its providers. The packet includes a provider directory, choice forms, and information on resources to assist with the plan choice process. Beneficiaries who choose a Medi-Cal managed care plan then receive a new member packet from the plan 10 days after enrollment. This packet includes a provider directory, member ID card, handbook, provider choice form so that they can choose their primary care provider. Medi-Cal beneficiaries who reside in county organized healthcare system or COS counties are automatically enrolled in a managed care plan. They also receive a packet 10 days after enrollment. In both the COS and the non-COS counties, plans will assign a primary care provider to a member if they have not made a choice of a primary care physician within 30 days after enrollment. Once assigned, a member can change their PCP at any time. And then, as mentioned earlier, we also maintain the website where people can review and find a primary care physician. Healthcare Options also has a call center that directly assists beneficiaries with questions on managed care plans and providers, including provider search assistance. Thank you.
Thank you. I have the gavel now. Are there any questions from panel members? Senator Pan.
Thank you. Actually, a couple questions because you mentioned, and I'm not surprised that what happens, you see an initial spike in ER use and it goes down after a year. Was the when you said that basically it returned back to basically something comparable? Was that comparable to other Medi-Cal rates, or is that compared to overall ER use rates, or including private insurance? I just want to know what the comparison was when you said that basically the ER use after a year was now comparable to others. Is it?
I'm not certain. I have to look at the study. I know it was they compared it back to individuals that had previous comprehensive coverage.
Okay, so it'd be good to clarify. Was that other people in Medi-Cal or also comparable to people in private insurance? And then and then also in terms of the, I think one of the concerns that because I know, and obviously this hearing is more focused on ER capacity and so forth, but one of the challenges sometimes we've seen in Medi-Cal is access to specialty care. Now, I guess the other issue that you brought up is that the data you were talking about, is this only people in Medi-Cal managed care? Does that include the fee-for-service folks too, or is it just the Medi-Cal managed care people? Because it sounds like you were only referring to managed care data.
In data as far as the how to find a primary care physician?
Well, no, in terms of the use, ER use data, utilization data.
This studied the LIP population specifically, the low-income health population, which was a precursor to the managed care program.
Right. So basically, these are all people in Medi-Cal managed care. No this was not Medi-Cal fee-for-service people. Okay. All right. So, I mean, I think one of the things that we do need to look at, and sort of maybe a little tangential to the main subject of this hearing, is the use of the ER sometimes if you can't get access to specialty care, you send someone to the emergency room because there'll be a specialist on call. If you can't get them in on an outpatient basis, and to what degree does that happen, and what we can do to try to mitigate that. So again, I think for managed care organizations, it depends on their network and the availability to subspecialty networks. But we can explore that perhaps in other hearings. So I appreciate the data. Thank you.
Thank you, Senator Pan.